We are going live in 3, 2, 1. We are live now. You may start.
Good evening, ladies and gentlemen. Welcome to another interesting episode of Blood, the Life Savior. And today is episode 19th. Today is July 29th, 2026. That means we have already crossed our 1.5 year landmark. And today we have two interesting case presentation, one on relapsed refractory AML and second on peripheral T-cell lymphoma. And the case presenters are Manipal Hospital, Bangalore. Warm welcome to you. I would also like to welcome our mentor, our coach, our course directors, Professor Dr. Biju George, sir. Thank you and warm welcome to you, sir. And Professor Joseph John, sir. Thank you and welcome to both of our program directors. Sir, have always guided us to start on time. It is 7 o'clock and we have started on time, and we always try to finish on time. Sir has also guided us to keep their presentations very brief. Both of you don't need an introduction, sir. Professor Dr. Biju George, proud director, CM Civil Law, Professor Department of Hematology at CM Civil Law, more than 300 plus publications in all the peer-reviewed journal, developed the fludarabine cyclophosphamide conditioning protocol, which we are all aware in aplastic anemia, and so many patients and family caregivers are thankful to Sir and his wonderful department, probably one of the best in Asia, for stem cell transplantation and infectious disease management and bone marrow failure disorders, which remain Sir's areas of expertise. Our second program director, Professor Dr. Joseph Johnson, we know him fondly, very well. Professor and Head Department of Clinical Hematology at CMC Hospital, Ludhiana. So one is in the southern part, second is in the northern part. Many awards and appreciations to Sir's credit as well. 30 international, 38 national publications, contribution to 7 book chapters of repute, PI of many clinical investigators trial, and Sir's areas of interest and expertise also remains hematology and stem cell transplant. And both of you have been giving huge amount of contribution to hematology because you have DM students in various parts of the world. Thank you, sir, for becoming our program directors, and warm welcome to you. May I request both of you to take it forward from here, sir.
Thank you, Dr. Manoj. Today we have two very interesting cases, very contrasting ones. One is the refractory leukemia. The second one is the peripheral T-cell lymphoma. So what I would suggest is, because these are two very different cases, we will try and spend about half an hour on each of them. We will have the first case presentation followed by the discussion and questions from the audience, and then we will move over to the second one. This is being presented by Manipal Hospital, headed by Dr. Mallikarjun Shetty, and we have two young residents who will be presenting it. Over to you, Mallikarjun.
Good evening, sir. Good evening to the team. It is wonderful that despite all the busy schedule, you've done so many of these, and thank you for giving us this opportunity. These are both interesting and difficult cases, so we'll be looking forward to inputs for both of you. And we have two of our wonderful residents presenting. We'll start with Dr. Moise. Moise, you can start, please.
Good evening, sir. Yes.
Picture go off your screen, please. Yes, Doctor. Please.
So good evening to one and all. Today's case is a 63-year-old female who was a resident of Sri Lanka. She presented initially at her local center in August 2025 with a 1-month history of fever and cough. So the baseline laboratory evaluation showed a hemoglobin of 9.6 with a total count of 33,700, platelet count of 33,000 with a peripheral blood blast count of 88%, A bone marrow evaluation was done at the center, which 7 hypercellular marrow, Sudan black stain being positive, suggestive of myeloid lineage. Flow cytometry was run, which was suggestive of AML with acute myeloid leukemia with aberrant CD7 expression. On the cytogenetic and molecular analysis, there was no targetable mutation which was detected. FISH was negative, which was suggestive of an adverse risk classification. So there in Sri Lanka, she received initially HMA and venetoclax, azacitidine and venetoclax for 5 cycles, after which a bone marrow assessment was done, which showed an MRD positivity of 0.3%, after which she was continued on 2 cycles further of azacitidine and venetoclax, after which the disease relapsed after 2 cycles with 52% of blast. Thereafter, she received 1 cycle of low-dose recitabine and venetoclax for 1 cycle, after which she persisted to have the disease. There was refractory disease there. Then 1 dose of low-dose cytarabine also, which was refractory. So here, what were the who had a disease relapse after 7 cycles of subsequent LDAC and venetoclax and low-dose cytarabine with no targetable mutations. She presented then to us via teleconsult in April 2026. So this is one study which was seen here. So this is a study of outcomes after hypomethylating agent and venetoclax failure. So they divided into patient subgroups who had relapse after the initial treatment, which was the overall survival was 4 months, with initial refractoriness being 1.2 months, the median OS. Treatment after when an HMA with best supportive care, the OS was 2.9 months, and with any other treatment, it was 4.1 months. The other being overall survival after, so with no response to any, the ones who had received salvage treatment, the ones who had no response to salvage treatment versus any response, so their outcomes were poor as well. I hope the screen can be seen, is visible to everyone.
Yes,
Yes, it
yes.
is.
Yes, okay. So here is one of the diagrams. So basically, a patient of relapsed AML, we first have a look whether the patient has any targetable mutation versus no mutation present. So here, our patient initially did not have any targetable mutations present. So if there is one, then if there is a FLT3 mutation present, we can target it with giltertinib. IDH1, we can target it with agents such as ivosidenib. IDH2, enasidenib, and menin inhibitors like mutation present, that is another different challenge. There we would have to provide a salvage chemotherapy such as flag ida or flag venetoclax or a ham based protocol or a clag m based protocol or a claya based protocol, and then if the patient is eligible for allogenic stem cell transplant, take it further. So this is one of the articles in 2025 ASH, American Journal of Hematology, the article which showed a treatment goal for patients with relapse refractory AL. When there is a mutation present, we would definitely an agent. Otherwise, we would go ahead with the salvage chemotherapy, assess for remission, and then take up for transplant based on eligibility. This was one of another study in which they compared protocols. There were two different studies. One which compared the different protocols of CLAG versus MEC versus CLAG M in relapsed refractory AML, with the median OS for 13.4 months for CLAG M versus MEC being 6.9 months versus CLAG of 6.2 months with a p-value of 0.02. There was another study which compared mitoxantrone-based salvage chemotherapy, where it was compared to, where the CLAG-M and MEC comparison was done, where there was no significant difference between CLAG-M and MEC in the median overall survival.
Moise,
Whereas
your
for the
slides are
ones who
not moving.
proceeded to transplant, MEC
Moise,
showed.
your slides are not moving.
Okay, sir. Yes, sir. Okay, sir. Is it visible now?
They're
Okay,
not moving.
I'll
You're
just come.
still at that.
Okay, sir. Yeah, just one minute.
Good night, ma'am. Sir, if you are facing any connectivity issues, I'll request you to just turn off your video and try to present your screen again. I think because of internet, it is
Okay,
not moving.
sure. Is it visible now?
Yes, sir.
Visible. Go all the way.
Okay. Yeah. Okay. So I hope the slide is visible now. Is it?
Yes, sir.
Yeah. Sorry for the delay. So in patients with relapsed refractory AML, if there is a targetable mutation, we would want to target it with one of the agents. Otherwise, we would go ahead with a salvage chemotherapy when there is no targetable mutation and assess for transplant eligibility and then take up for transplant. So there were two studies. The first one, which compared the salvage chemotherapy protocols in relapsed refractory AML, where CLAG-M versus MEC versus CLAG was compared. The median overall survival being better for CLAG-M, about 13.4 months, versus MEC and with 6.9 months, and CLAG being 6.2 months with a p-value of 0.02. The second study was from Norway, which showed efficacy of mitoxantrone-based salvage therapies in relapse or refractory AML, which showed no significant difference in the overall survival for patients between CLAG-M and MEC. So our patients were offered. So then we gave the advice to go ahead with the flag light protocol. So the patient then in Sri Lanka received flag light protocol based on fitness. Day 1 to day 5, fludarabine being 20 mg per meter square, cytarabine 1 to 1.5 gram per meter square, and the GCSF. After which the patient still had a refractory disease, then definitely it comes down to fewer options. The patient received CLAG-M after that for the first 5 days, even to which the patient had refractory disease and persistence of blasts. There was no decrease in the blast count even after receiving CLAG-M protocol. Then after that, the patient received CAV protocol consisting of azacitidine, cladribine, and venetoclax 100 milligram OD till day 14, to which even the patient had refractory disease. So what next? Now the patient was came to a center in June 2026 with a low-grade fever. On examination, she had pallor present. She was febrile and had tachycardia. There was no organomegaly-lymphadenopathy on examination. The lab evaluation at our center revealed a hemoglobin of 9.5, the total count of 14,800, and 56% blast, and thrombocytopenia, platelet count of 46,000, with peripheral smear suggestive of an acute myeloid leukemia, with a procalin CRP being positive. We ran a peripheral blood flow cytometry with the immunophenotyping features being suggestive of an acute myeloid leukemia with an aberrant CD7. We ran a peripheral blood FISH karyotype and an NGS. The FISH revealed duplication of BCR alleles and 3 copies of BCR with trisomy of chromosome 22, no other FISH abnormalities. The karyotype revealed a deletion of chromosome 8 and trisomy 22. While the myeloid NGS was positive for TET2 with a VAF significant, KRAS of VAF of 4.5%, and CSF3R with a VAF of 49.1%. So what next? We initiated the patient on MEC consisting of mitoxantrone, etoposide, and cytarabine for 5 days, where she received mitoxantrone 8 milligram per meter square IV once, etoposide 100 milligram per meter square, and cytarabine 1 gram per meter square IV. So now I would want to divert the attention here of our audience to one more point. We wanted the patient to be taken up for transplant. The patient was at that moment the intention of going ahead with transplant. The donor being the son, the donor was a haplo donor. So we ran the donor specific antibody. There was a high titer donor specific antibody in the class 2 being very high, the MFI being 17,889 in the DQA1, DPB1 as well, and DQA1 0101 and D10501 as being having a high MFI. And class 1 HLA also being high MFI of 9,255. So this is a barrier to the transplant. So what is the clinical impact of the donor-specific antibody on the primary graft failure? So as we can see with the donor-specific antibody being positive, there is a primary graft failure rate of 32% compared to when it is SA negative. The overall survival being with more than 20,000 MFI, only about 0 to 20% being the overall survival compared to when there is no DSA. So clearly when there is a high titer DSA and when you do not clear it, there is a chance that your graft may be rejected. So how have the DSA detection assays evolved over the years? now we use a solid phase, which is next, which allows identify specific HL leaves and provides immune fluorescence. It has the highest sensitivity when we compare it to other assays, which were cell-based assays and flow cytometric-based cross-match assays. Cell-based assays have a lower sensitivity compared to the solid phase and the flow cytometry cross-match. The advantage being that in cell-based assays, here it detects the complement activating antibodies as well. So the ASTCT and EBMT guidelines, they firmly recommend a solid phase immunoassay, the Luminix assay, for the screening. Also, what is important here is to detect a complement binding DSA. We must do a C1q assay, which isolates the complement binding DSA. With a C1q positivity of more than 10,000 highly correlating. And patients who remain C1q positive at the time of stem cell infusion, they face almost 100% rate of primary graft failure. So we ran a C1q test result as well, which showed very high FI value validation, the class 2 1q. So what does it is 2000 minimal risk, more than 20,000 for other donors, and a high risk to 20 is the risk of primary graft failure, and patient must do desensitization protocol. So we must screen all candidates with a solid phase immunoassay within 1 month of conditioning. With of more than 2,000, we must C1q assay and flow. If there is a 2 to 20,000 of MI, we must initiate desensitization protocol. If more than 20,000, alternate search must be made. And the desensitization arsenal consists of 4 modalities. Number 1, physical removal by plasmapheresis, of production by rituximab, against the C20 B cells, neutralization by IVIG 1 gram per, and we also can give variety buff code, add around my utilize Anderson protocol every 15 to day minus on day minus 10, 1 dose on day minus 9, and followed by standard conditioning with an irradiated buffy coat infusion. So coming back to her disease, she had blast persisted to be about 12%, after which she was administered 1 cycle of decitabine, cytarabine, and venetoclax from 4th July to 13th July, after which she again persisted to have disease, refractory disease on board. At the same time, we also started desensitization. We gave 1 dose of 2 doses of bortezomib and 1 dose of rituximab as well. So now what next? We counseled the patient and family regarding the poor outcomes, since after exposure to so many lines of therapy, the patient continued to have a refractory disease. There was persistence of blast. At one point, the blast even increased to about 70%, and even the risk of proceeding with further treatment. Is there even any outcome? What would be the outcome of even going ahead with transplant? And also DSA positive. So as I told, we proceeded with the desensitization strategy. She received rituximab and bortezomib. The only alternative here left was she had no past exposure to anthracycline. So we went ahead with a 7+3 here. We exposed her to Dono and cytarabine from 17 July to 23rd July. But there was no decrease. What was even shocking was there was no decrease in blast percent. Even at day 7 of cycle initiation, the blast stayed at 40%. So this is what in our experience really humbled us, and we've never faced such a case where the patient has refractoriness to so many lines of therapy. So this was an elderly female patient with relapsed refractory AML after failure of frontline azacitidine and venetoclax, multiple subsequent salvage regimes, and highly chemo-resistant disease. There was no targetable mutation present in this patient. And despite sequential escalation, there was one more thing which I wanted to add was when we gave her the decitabine, cytarabine, and venetoclax, we even escalated the dose of venetoclax to 200 milligrams to was no response, not have the blood that therapeutic anthracite 7 induction with probable bridge
The sound seems to be breaking.
transplant strategy along with the related. So it shows that once a patient could be okay.
Yeah, go ahead. Go ahead.
Yes. So this was a humbling experience for us because we have not seen such a patient with refractoriness to multiple lines of therapy, and in spite of so many lines of therapy, the blast never came down. She did not go into any kind of remission after coming here, and even when in Sri Lanka, she received the multiple lines of therapy after the initial relapse. She never responded to any line of treatment, including the anthracycline, which was administered as a desperate measure. So I would like panel with uh, as well, sir, and Dr. Joseph, sir. Thank you, sir.
Thank you so much. Yes. Unfortunately, we get some of these difficult cases like this, and at some time we have to decide whether we do anything at all if this is a truly refractory AML. So there is one question from Dr. Saurabh Bave asking, was it CD38 positive or not?
Uh,
You put that flow report, no, Moise?
yes, yes, I just put that. Yeah.
So we have our
Yeah.
flow panel, at least acute ALL they have, sir. So we use DARA for refractory TALL.
So there was CD38 bright, sir. In on the flow cytometry, there was a positive expression of CD38, which was bright here.
No, I agree that people have used daratumumab in refractory ALL, but is there any data on using it in AML even if you're CD38 positive?
No, sir. There was no data of daratumumab that I could find with multiple refractory AML, sir.
Yeah. Saurabh, do you have any experience? Okay, yeah, I mean, I think in such a case, the only thing that would have helped is if this lady had a targetable mutation. Unfortunately, even at the time of relapse, when you did an NGS, you couldn't find a targetable mutation. And such patients are usually very refractory. So somebody's asked, should consider NK cell therapy or alloCAR trials for this patient. So I know we have tried cytopenia transplants with NK cells. The outcomes have been very, 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 very poor. I don't think there are any alloCAR trials for AML in India. So I think there are no. I am not. As far as I know, there are no trials for refractory AML going on in any place in India. Joseph, do you know anything?
No, this is a really tough case. I think we have to just say we've tried enough records.
I totally agree with Joseph. At some point, we may have to say that. If it was, on the other hand, a 20-year-old, you may decide whether you want to go ahead. But at this age, I think she's had almost 8 or 9 lines of therapy. At some time, we have to say stop, and we have done the best that we could. And sometimes
Yeah, I think
that's an art we
Yes.
need to learn in hematology, of when we say we've tried enough and not just keep on trying when we know that the chances are probably less than 5%.
see, she's 63 years old. The life expectancy in India is 72. I don't know in Sri Lanka how much it is. So that is
Oh,
another way to talk
so
about to them is saying that the best case scenario should have been another 10 years, but with
Yeah.
this,
No.
it
So
is.
I was quite surprised she reached us. In fact, I was surprised it survived all these lines of therapy. So in fact, every time they did the video consult, I asked them, please stop, please go back home. The poor lady kept on staying in the Sri Lankan hospital. She came here. I hope now she goes back home, but I'm told she's not given up yet. She's going to
Okay,
search for other teams. Yeah.
okay.
Yes.
Sure. Are there any further questions? I think the questions in the Q&A have been lenalidomide, can it be tried? Uh, I am not too sure whether when you fail 7 lines of therapy, lenalidomide is going to do anything. I know people have tried everything, including oral melphalan for AML, but I'm not sure how much it's going to work in such a refractory situation. So we will move forward and we'll just go ahead to the second presentation. Joseph, can you take it from here?
Yeah. So who is presenting the second case?
Sri Teja. Sri Teja.
Same person. Okay.
No, Dr. Sri Teja. She will present now.
Yes. Good evening, everyone. Today we'll be discussing a 56-year-old female who presented to us with a 18-month history of recurrent erythematous indurated skin lesions all over the trunk and extremities, and 1 year history of multiple painful subcutaneous nodules over elbows, hands, and lower limbs, and 1 year history of severe unintentional weight loss, about 10 to 20 kgs, and 1 year history of polyarthralgia with morning stiffness, and 3 to 4 weeks of progressive painful generalized lymphadenopathy with intermittent fever in November 2025. So there's an 18-month history of progressive clinical evaluation and transient steroid responsiveness in this patient. Initial onset was with intermittent erythematous skin lesions, which were partially responsive to corticosteroids and immunosuppressants, initially treated as a chronic inflammatory or autoimmune dermatosis. Later, she developed musculoskeletal and systemic onset symptoms, which include painful subcutaneous nodules, inflammatory polyarthritis, and morning stiffness and weight loss. When she presented to us, she was having a new lesions over the back, neck, parotid, and tonsillar regions, and rapid onset generalized painful lymphadenopathy involving cervical, axillary, and inguinal. And multiple prior dermatology and rheumatology evaluations prove inconclusive prior to a presentation at MHP. So coming to the past history, she is known case of diabetes. She is also a known case of autoimmune thyroiditis with prior history of steroid responsive inflammatory skin disease requiring corticosteroids. She was initially started on prednisolone when when they were tapering the steroids, the skin lesions reappeared. After which she received MMF, and she was also put on tofacitinib for a while. She also has a history of polyarthritis with nodules on the extensor aspect of the forearm in the in the past, treated with steroids and immunosuppressants. She's a known case of she developed drug allergy to amoxicillin in the past. No negative history, no history of tuberculosis or CLD in the past, no history of malignancies, no surgeries and transfusions in the past. The previous evaluation prior to the presentation at MHP, in 2023, there was an initial skin biopsy, which was reported as an inflammatory or connective tissue disorder. Dermal sclerosis and mucin deposition was noted on the microscopy. In February 2026, there was one more biopsy, which was reported as a morphia. In 2024, mid, there was a lymph node biopsy, which was reported as a reactive lymphadenitis. And there's one more extensor biopsy in October 2024 of the extensor aspect nodule, which was suspected to be a rheumatoid nodule. So that was also suggestive of an inflammatory nodule. So summarizing general examination, she's a good her ECOG performance was 1. She was afebrile during her presentation and hemodynamically stable. On examination, she had multiple bilateral cervical, axillary, and inguinal lymph nodes, with the largest measuring 3 into 2 centimeters, which is firm, discrete, and mobile, and mildly tender. Cutaneous findings were multiple erythematous indurated plaques, nodules, hyperpigmented heel plaques, and areas of sclerosis, and tender subcutaneous nodules over the elbows, hands, and legs. Musculoskeletal system, 10 swollen joints and 5 tender joints were there. Tender nodules were the extensor surfaces, and cardiovascular and respiratory system examination remains unremarkable. These are the skin findings which we have noted over a course period of time. There were multiple erythematous lesions on her knee, on the back, heel scars, and erythematous plaques over the lower limbs, and the edema. So there was a diagnostic dilemma all throughout. So summarizing the case, it was a 58-year-old female who was at the autoimmune background with an 18-month steroid responsive blocks plus progressive subcutaneous nodules and polyarthritis and 10 to 20 kg weight loss and rapidly progressive generalized lymphadenopathy. At this point, we can have a DD of connective tissue disorders, then IG4 related disorders and sarcoidosis, infections like TB, fungal infections, and hematolymphoid malignancies, which can be cutaneous T cell lymphomas, peripheral T cell lymphomas, extranodal NK and T cell lymphomas, systemic lymphoma with secondary cutaneous involvement. Then we proceeded with the lymph node biopsy and a forearm skin biopsy. So, right forearm skin biopsy was suggestive of a cutaneous involvement by a mature T cell lymphoproliferative disorder. Right inguinal lymph node biopsy was positive for CD3, CD2, and CD5 with downregulated CD7. And CD8 is diffusely positive. K67 was 60%, GATA3 was positive, this ALK was negative, and BCL6 is negative, and CD56 is negative, in Iberish was negative. So at this point, we have made a diagnosis of peripheral T cell lymphomas, CD30 positive, with 10% of the tumor cells not otherwise specified. Going back, she has a multiple PET CTs starting from 2023 to Jan 2025, and we have repeated one more. In November 2023, her scan PET CT revealed diffuse subcutaneous soft tissue edema with low-grade FDG uptake, no convincing evidence of lymphoma in 2023. There's one more PET CT which was done in Jan 2025, which was showing complete resolution of the diffuse low-grade FTG of its subcutaneous edematous changes. They were non-avid cervical lymph nodes in level 2 to 5 and supraclavicular lesion and upper paratracheal and retroperitoneal and external iliac regions, with stable low-grade uptake in the axillary and the inguinal nodes. In November 2025, when she presented to us, we got a repeat PET CT done, which showed a rapid systemic widespread extranodal involvement, which was in multiple metabolically active cutaneous and subcutaneous lesions, and intermuscular lesions. And intrathoracic and pulmonary, there are pleural-based soft tissue lesions abetting the right ninth rib and non-FDG avid nodules in the middle and left lower lobes of the lung. Then low-grade FDG avid ill-defined hypodense lesions in the left retroareolar of the breast, and skeletal and marrow, multiple metabolically active deposits were noted. Significant increase in the size and number and metabolic activity of the prior lymph nodes involving stations above and below diaphragm were noted during her PET CT done in November 2025. So, summarizing the presentation, it was a stage 4 disease with the CD30 positive tumor cells around 10%, with Iberish negative, ALK negative, and Ka67 was 60%. With this report, we have started her on therapy. We have reviewed the data. So there was a Echelon 2 trial, which was showing BVCHP nearly doubled the median progression-free survival to 48.2 months and improved 5-year overall survival to 70.1% versus CHOP. We have started her on BVCHP after reviewing the data. So first line, we have given her BVCHP therapies. We have got a PET CT done after the cycle 2, which was showing a reduction in the FDG avidity of the nodules, cutaneous lesions, and the marrow lesions. Overall, it was reported as a partial metabolic response. We have completed her other 4 cycles as well. After completed 6 cycles of BVCHP, we have got a repeat PET CT done. End of treatment PET CT done in May 2026 was suggestive progressive metabolic disease with interval increase in the number, size, and metabolic activity of the bilateral cervical, axillary, and inguinal lymph nodes. Largest is the right level 2 cervical lymph node, which was 2.1 centimeter, with increase in FDG avid cutaneous, subcutaneous, intramuscular soft tissue dip, and hypermetabolic marrow lesions. So at this point, we have got a repeat biopsy done from the progressing nodal and cutaneous lesions. So rebiopsy was reported as a 85% component with a T cell component and 15% as a B cell component. The T cell component was positive for CD3, CD2, CD4, CD5, ICOS1, PD1, and BCL2. with patchy CD10 positivity and BCL6. CD30 was similar to 5%. In Ka67 was 50 to 60% with negative for CD7 and CD8. Whereas a B cell component was secondary to EBV positive, was reported as the EBV positive DLBCL, which can be secondary to a T cell AATL. So markers were positive for CD20 positive, Iberish positive, CD30 was around 40% positivity, MUM1 was more than 30%, PAX5 was patchy positivity, and Ka67 was 95%. And concurrent back skin lesion was biopsied, which proved the same level, which was showing a nodal T cell component markers CD4 and CD8 and EBR negative. At this point, we have reviewed the data. What is the mechanism? We'll review the data on what's the mechanism of development of a composite lymphoma. So the disease of a T cell lymphoma begins prior to the clinical lymphoma presentation. A normal hematopoietic stem cell gets a TET2 and DNMT3A mutations inherited by all blood cell lineages. These create a pre-malignant clone. Following which the T cell specific transformation occurs, which gets an acquired mutation, signature driver mutations like ROA, G17V mutations, after accompanied by IDH2 or CD28, PLCG1, VAV1, and F1 mutations. The malignant phenotype is a normal T follicular lymphoma cell, converts into a malignant TFH cells. It retains characteristic diagnostic markers of PD1, ICOS, and CXCR5, and BCL6, and CXCL13, and CD10. So what is the mechanism why they present with an autoimmune manifestations? So the malignant cell confines to 10% of the total cell burden, where the 90% will be the reactive inflammatory cells. So the malignant cells release IL-4 and IL-21 and CXCL13, which causes vascular proliferation, which results in autoimmunity and autoimmune manifestations of the disease quite early before the malignancy manifests. And the secondary malignancies like EBV positive B cell clone with the DLBCL as a diagnosis in line. So conclusion, there are two ways a malignant T follicular helper cell can do. One is a pro-inflammatory cytokine release and immune dysregulation causes the early skin lesions like morphea, polyarthritis, and transient steroid responsiveness in this patient can be secondary to this mechanism. Whereas the other one is aberrant interactions with the B cell in an immune-compromised microenvironment permits the uncontrolled proliferation of an EBV-driven secondary clone, culminating in the aggressive DLBCL relapse. So how to identify these lesions? Anticipate it quite prior to the malignancy manifest. Mandate a rebiopsy whenever you are suspecting a progression, and a multimodal diagnosis including molecular profiling with TET2 and DNMT3A. So at this point, we made a diagnosis of a relapsed T cell lymphoma and DLBCL after a BVCHP regimen. So we have reviewed the data at this point. There was a case series which were published who have received the treatments. So most of them were if we are treating a treatment new patient with this manifestations, we can go for a CHOP or R-miniCHOP and lenalidomide or brentuximab vedotin and rituximab. Whereas our patient already received the BVCHP regimen. So then we are left with only quite a few options. If the patient is transplant eligible, then we can give up with ICE, DAP, and GDP or gemcitabine based regimens in combination with rituximab. So here we have proceeded with R-GEMOX regimen. She completed her 2 cycles of R-GEMOX. She is awaited for the PET-CT for this month. So in another case, if the patient is not eligible for the transplant, then we can try with the single agent therapies like romidipsin or belenostat and continue with the same. So thank you. So hello, sir.
Yeah. I think Sridhar, I think you completed, no? Okay. I think Dr. Joseph.
Yeah, so very, very interesting case.
Yeah. So ultimately, can you just summarize what is the final diagnosis? Is it a relapsed AITL, PTCL, NOS? Do we have a T cell rearrangement here at any point? I may have missed it.
No, no, sir.
Okay, so just just summarize the age of the patient, please,
So
for
it's a
everybody's
56-year-old female who presented
with
with
history of 3 years history of skin lesions.
with 3 years,
And
18 months history of skin lesions, joint arthritis complaints, and rheumatoid nodules on the extensor aspect of the arms, with the weight loss and with the multiple palpable lymph nodes in the cervical, inguinal, and axillary regions, who was initially diagnosed as a PTC, who was initially diagnosed as a
yeah,
peripheral T cell
PTC.
lymphoma, PTCL, after which she received 6 cycles of brentuximab vedotin and CHOP combination, CHP combination, and she relapsed after the 6 cycles of BVCHP. Then we attempted it when we got a
No,
review of. Yes.
One sec. When you say 6 cycles of BBCHP, what was the interim assessment after 3 cycles? It is
So we have done an
relapsed
interim.
after 6 months of stopping.
Yes, sir. After 2 months, we have done an interim PET CT. It was in partial. It was a partial response, sir.
Okay, and then
Then we have
so we
continued.
continued for 6 cycles. At the
Yes.
end of 6 cycles, PET again showed progressive disease.
Yes, sir. Yes, sir.
Okay. Okay, and then what did you do after that, treatment-wise?
After the end of treatment, PET CT was showing multiple new lesions and worsening of the increase in size of the previous lesions. So I've done a repeat nodal and a skin biopsy, sir. That was showing a composite lymphoma with 75% of it is a T cell component AITL, and 15% of it was a DLBCL, sir.
Okay. Okay, so it is a Richter's transformation type of thing, or was it massive nodes anywhere, LDH very high? T can rarely transform to a Richter for sure, especially ATL and all that. But there was no convincing evidence there. It was not a DLBCL, right? It is just a B cell
Yes.
component, which is you're saying the 15%.
Yes, sir. Yes, sir. Yes, sir.
Okay. So have you, so subsequently have you treated, or we are at
Yes, we have.
crossroads?
Yes, sir. We have given her our Gemox, sir. 2 cycles she has received till date, sir. She is due for her assessment this month, sir.
So what is the response rate as of now? Response of the
As of,
Gemox?
as of now, she's her clinical status was much better, sir. Performance is better. Weight gain is there. The nodes were the palpable nodes which were there before, the size have come down. We are waiting for her PET CT, sir, at this point.
So, like
Yeah.
Sritesh did not clarify. So the node biopsy was composite lymphoma this time. However, the skin biopsy was PTCL.
PTCL.
And even after treatment, the nodes have regressed. However, the skin lesions haven't. If anything, there are some new lesions. Yeah.
Yeah, Dr. Biju has some questions in the group.
So I was very interested. I think it is PD-1 positive. So why did you consider adding PD-1 inhibitors, either nivolumab or pembrolizumab? Because 85% of your content, whatever you have, is T cells. So that is what is driving the disease.
Yeah.
So I think if you, like you said, Mallikarjun, if you find that on your PET assessment that the disease has not come down, you still could, because we use Nivo GCD or pembrolizumab GCD to get them into remission, because ultimately only if you get this patient into remission can you do something beyond that.
Correct. Correct.
So
we thought.
I think, yeah.
Yeah, so we thought the consolidation that allogenic transplantation is the most important thing. We're hoping and praying that she would achieve a CMR with this so that we'll avoid the issues of using Nivo-Pembro. However, I think it is going to be what would be necessary now.
Yeah. No. So we have used Nivo in the past in Hodgkin's and then taken up for allogenic transplant. As long as you're able to give at least a 4-week gap between the last exposure to Nivo and then going ahead with the transplant, you do not have too much of problem.
Sure.
Well, it's very
Also,
interesting.
this kind of thing, there is another thing you need to keep in mind is sometimes one of these rare IEIs, late presentations, can happen. This age-wise, she's 50, but we have had our, fingers burnt on sending a whole genome sequencing may be helpful because sometimes rarely PI3K deficiency, etc., can present like this, which in fact counterproductive when you give Branta. Sometimes the disease just comes back. So the disease name, it's an abnormal proliferation which can look like an AITL. So AITL is a mimicker for many. Please understand that. And a TCR rearrangement can be of benefit here to assess clonality. Those are my 2 cents from some of the lessons we have learned earlier.
Sure.
So, Joseph, there is some Q&A.
So, yeah, the chameleon model. So, anyway, there is one question Dr. Saurabh Bhave has mentioned. In the AML, when you are pushed to the wall, nothing more to be done, throw in lenalidomide, at least something can be given if you want to give something. So that may be an option there as a option when you are pushed to the wall. So, any other thoughts from any other, the participants here? We are learning collectively here. There are no major answers, definite answers we can get, but only a discussion on the possible hacks you may have in your experience. You can share it here.
So, Joseph, I think in the Q&A, there is one question from Dr. S.G.
Okay. Q&A, what is there?
The last one.
Can we go for what do we do? When
No.
do you do an IPET in T-cell lymphoma after 2 to 3 cycles? Can you share your practice? When do you define something BV refractory? Is there any definition to that? I'm not privy to that information. Dr. Biju, is there any definition for
I
a
don't.
BV refractoriness as of now?
No, generally, I think if there is progression of disease beyond 3 cycles, in T cell, we generally do the PET only after 3 cycles. But even after 3 cycles, it all depends upon clinically is the patient responding or not. The PET makes some value only if clinically it is complete response and you want to assess depth of remission. Clinically, if the nodes are sitting at the same size, doing a PET makes no sense. Can we, ASA-based therapy is something that people use in AITL, but that is mainly for first-line therapy. That is where it's commonly useful. I don't think it's very useful when it is refractory and progressive disease like this. Are there any other questions from anybody, panelists?
Yeah, I think Biju, we can, if there are not many other questions, can we conclude?
Yes, yes.
So just I'll pick your brain. So let's say for the sake of argument, we do the PET scan and then the nodal disease has decreased. However, the skin lesions are there. So we do Nevo/Pembro-based single agent therapy and proceed for allography.
Yes. So this patient is not going to benefit from an auto. We have already gone beyond that stage. So it has to be allo. Even in allo, we have to remember that the best that we can get the disease under control before transplant, the lesser chance of relapse. So I would definitely consider PD-1 inhibitors before to get the skin disease under control, probably along with some other chemo, not just single agent. So either GCD or something else to get the disease under control, or mime, whatever you can give. Because mime has got this thing, ones which have got cytarabine that penetrates skin very well, and then get them into a reasonable remission and then go for an allo, including doing a haplo if you need.
Sure.
The patient, so that it's one patient or
Okay, I think Joseph, you can close, or otherwise I will close. So
Yes, we can close it.
Joseph, please. Okay. So we've had two very interesting, difficult cases, but these are probably cases that we see clinically, and sometimes it's difficult. Like for example, the first patient, the question is when do you stop? Sometimes we are lucky if the patient runs out of finances and says stop because I do not have any finances to go further. But sometimes your patients who are on the older side have finances, but you know in your heart of hearts that your prognosis is very, very poor. And so sometimes we have to have that conversation with the family to tell them that things are not going to work out. The second one is again an interesting case of lymphoma, starting with the PTCL progressing, then looking like an AITL along with the DLBCL, but this is a younger patient where there's a good chance of response followed by an allogeneic transplant. So I like to thank the team from Manipal, Dr. Mallikarjun, Dr. Moiz, and Dr. Sriteja for presenting these cases, and I'll hand this over to Diksha.
Thank you so much, sir. So, as we conclude today's session, I would like to begin by sincerely thanking the entire team from Manipal Hospital, Bangalore. Our appreciation for the excellent case presentation by Dr. Moiz and Dr. Sriteja, and our heartfelt gratitude to Dr. Mallikarjun for his insightful summary and guiding today's session. I would also like to thank our respected course directors, Dr. Biju George and Dr. M. Joseph John, for their constant guidance and support in shaping this initiative. And finally, thank you to all our viewers for joining us and being a part of this learning journey. We look forward to your continued association in the upcoming sessions of Blood the Life Savior. Thank you so much and have a wonderful evening. Thank you, sir.
Thank you. Thank you.
Thank you. Thank you.
Thank you, sir.